All right, excellent. All right, so first I just want to introduce Justin Feldman and Abby Cartus and see if they want to tell us a little about themselves, their background, what brought them here. I don't know if I'm supposed to call you doctors, what the official rules are. You guys can tell me.
Abby?
So my name is Abby Cartus. I am from Pittsburgh, and I just finished my PhD in epidemiology from the University of Pittsburgh. So you can call me doctor if you want, but you totally don't have to. A little bit about me. My undergrad degree is in molecular biology, and then I got a master's degree and a PhD in epidemiology. And you should be aware that my expertise in epidemiology is actually not in infectious diseases. So I trained in like perinatal epidemiology. So like maternal and child health, I guess is what we would call it. But I do have some, biological training and some epidemiological training that's applicable to this situation. You should also know that ideologically, I am very aligned with, you guys. I was a union organizer with the effort to unionize graduate students at the University of Pittsburgh with the United Steelworkers. And I have, educators in my family. My mom was a public school teacher in a couple of suburban districts around Pittsburgh, as were other people in my family. So just those are the pieces of information that you should know about me in evaluating what I'm going to tell you.
I'm Justin. I am in Jamaica Plain, Boston right now. I am also an epidemiologist. What was I going to say? So I studied environmental and occupational health and worked in those areas for a few years. Then I got a doctorate in epidemiology. My work now is often about police violence and also race and economic inequalities in health, especially COVID these days. I too was a union organizer with the United Auto Workers during Harvard's successful attempt to unionize the PhD students there. And my dad was a public school teacher in New York for 30 years.
I didn't realize you were both public school backgrounds like that. That's super cool. So I do want to get us started on some more of the science questions. So the first one I had for you guys was just like, what can you tell us about COVID in kids? What do we know? What do we not know? Yeah.
So I can start, I guess. There are some technical questions that, okay. The bottom line is children can get COVID, children can spread COVID. That's basically what you need to know. There's some more specific arguments that people are making, especially when they want to downplay the risk of schools. They're saying that children are less likely to get COVID than adults, and they're less likely to spread COVID than adults. That's somewhat true, but it's more complicated than that. It's true if you're under 10 years old, and it doesn't account for behavioral differences. So on any one time, say a 9-year-old is exposed, they're less likely to get COVID than if an adult was exposed one time, but their behaviors are different. And we see in countries where we have better data, like the UK, kids get exposed more. And in the UK, high school students were by far the most likely to be the first COVID case in their household. It was 8 times more likely than someone older. And even younger elementary school students were more likely than adults to be the first case in their home. So they do play a role in getting and spreading COVID to older people, even if they're not getting very sick themselves. Often they have no symptoms and you wouldn't know except for testing.
Abby, do you have anything to add, or is that a good rundown?
Yeah, I think that's a good rundown. The thing that I would add, there has been a lot of UK, a lot of data coming out of the UK, I feel in recent weeks showing these kind of alarming, rates of infection among school-age children. I think one caveat is that I have heard, it's my understanding that masking is very uncommon in English schools. So everything Justin said is true. And to contextualize it, it's my understanding that mask compliance is like not, or hasn't been very good in UK schools. So that's just something to consider.
Awesome. You're going to find that some of these questions are going to like loop back around again. So if you feel like you've already answered it, you can just say, I feel like we've already done that one. So the next one was like, what about COVID in schools? Just like what roles do schools play in COVID transmission? And then also, what kind of transmission happens in school? Because I feel like those are two different questions that don't always get distinguished.
I feel like I spend half my life waiting for Justin to talk first.
I could start. Well, I just started. You can start this one.
In terms of transmission in schools, I mean, I think there have been a lot of assertions floating around that, transmission doesn't happen in schools, or, that it doesn't happen if proper mitigation strategies are employed. I think it's pretty clear that transmission can happen in any kind of, congregate setting. Any place where lots of people, are gathering together, especially if it's indoors, is potentially a setting where transmission can occur. I think it's common sense to me that like mitigation strategies can work, but I feel like the only way to guarantee that transmission, absolutely will not happen is to have virtual instruction. I think mitigation measures can potentially greatly reduce the risk of transmission in schools. But I would be skeptical of claims. We were talking to another group of teachers that were told by the state that they're in that, transmission, fully can't happen in schools. And I would be skeptical of any assertions to that effect, because we really don't have very good, or I think like very adequate data to evaluate the effects of different mitigation strategies. But I don't know that I can necessarily point to any specific data, because I think frequently we're not doing like outbreak investigations to identify the sources of outbreaks. But, it is definitely possible. And it has, I would bet a lot of money that it has happened, transmission in schools has happened in the United States. Like it's just a possibility. It's like a fact of biology that a respiratory virus can be spread in indoor congregate settings, especially, the risk is much higher if mitigation strategies are not employed.
Yeah, and just to put Somerville's plan in like a bigger context, what Somerville is aiming to do is much, much better than the average. It's a plan that will test almost everyone weekly or twice a week. They put, from what I understand, a lot of money into ventilation. There will be physical distancing. There will be almost universal masking. These things will all definitely help. It doesn't mean spread won't happen in the school building. It probably still will, because these systems can break down. Two, even when they're in place, nothing's perfect. And then you can also think about spread that doesn't happen in the building, but does happen because schools are open. So right now, you're probably mostly living your lives at home right now. Once you're going in 4 days a week, you will be interacting not just with school more, but you have to get there. You'll have less time to cook your food. So you might be going to a restaurant more to pick up food, just like increases the number of times you're going to be interacting outside of the school building with the community.
I muted myself and forgot I muted myself. My bad. Okay, so my next question was actually on mitigation strategies, and this one might be more for Justin, because I know you spoke at school committee last night, and I think you've looked pretty closely at the mitigation strategies. As you're like thinking about the mitigation strategies that are happening in Somerville, can you just like talk about which ones feel like the most important of the mitigation strategies? Because I know that you're talking about things are going to break down, and as we're thinking about things breaking down, you know, which ones are really problematic if they're not working?
Yeah. So masks, definitely important. Having people 6 feet apart and wearing masks at all times. Um, if people don't have masks, or if you're pretty close and have a mask, like especially if it's a cloth mask, because spread can still happen. It's less likely, but it can still happen. The testing and quarantine is going to be huge. That will allow you to catch some big chunk of active infections and to isolate everyone who's infected, and to make sure every close contact stays home. So those two pieces, the masks and the test trace isolation, are going to be the key pieces that you need to be thinking about. Ventilation, like I'm assuming it's just there and going to work and you're not have to think about it. But the mask, test, trace, isolate.
So a quick follow-up on that is about the masks in particular. It's one of my later questions, but we can just hop to it right now, right? One of the things that is going to lead to that breaking down is going to be kids eating, right? And the other one is, you know, they've been talking about kids getting mask breaks in school. I was wondering what your thoughts are on kids eating in school, mask breaks in school, you know, what you do in those situations.
Yeah, I think if I remember the way that you had you gave us like a list of questions to look at. And if I remember the way you posed it, it was about, you know, like having kids eat in the cafeteria versus in classrooms unmasked. And I think my sense of that, you know, I like, again, I'm not an expert about infection dynamics in, you know, closed buildings, but my sense is that it all depends on how far apart, you know, students can sit and how well ventilated the rooms are. I think that those are probably the biggest deciding factors as to whether, you know, it's, you know, it might be safer to have kids eat in the cafeteria if they can spread out farther, and if, you know, the cafeteria is better ventilated. Whereas, you know, if the cafeteria is just kind of a closed room and kids would have to sit together at kind of long bench tables, it might be safer to have kids eat in classrooms that might be better ventilated. I think another consideration in terms of thinking about, you know, cafeteria versus classroom is that keeping kids that are sort of in one class together for lunch could potentially be safer than possibly putting kids from multiple classes together, you know, in the cafeteria or a setting like that. I think having, you know, kids eat in their classrooms could potentially, you know, contain, if one of those kids is positive, then, you know, it could sort of contain transmission, any transmission just to that class, rather than potentially exposing, you know, that kid who is positive and might not even know it, you know, to kids from other classes. So I think it just depends on how well, you know, mitigation can be implemented in like the cafeteria versus the classroom setting. In terms of mask breaks, I think that really depends on the setting too. I can think of situations where a mask break would be safer, you know, something like a recess, you know, if kids are outside and are encouraged not to get too close to each other, you know, I think that could potentially be like a safer way to do a mask break. But doing mask breaks in the classroom, especially, you know, if it's a little tight and kids aren't sitting, you know, quite 6 feet apart, I would feel more wary of that. That seems like a riskier activity, but I don't know if Justin has anything to add to that.
Yeah, I hadn't heard of the mask break idea. Like, when you're not wearing a mask, you can spread, and it only takes really a few minutes. Like, yes, the risk is lower if you're farther apart. It's lower if it's well ventilated, but it just seems, I don't know. Like,
It seems risky to me. Like, I wouldn't like recommend it necessarily. But I feel like it's kind of, it's like a gradient of like riskier versus like less risky ways to implement it, I think.
Awesome. Thanks, guys. So the next one I had was, you know, specifically about asymptomatic spread of COVID. In some places I've been reading, they are doing, attestation forms that you don't have symptoms. And, a question I just have is like, is that even like worthwhile given the level of asymptomatic spread that might be existing, or, especially on kids, just wondering what your thoughts are on that piece of it.
Yeah, so kids will often never have symptoms, or they'll be mild, where maybe they feel like it's just a cold. Um, it is good to not have someone knowingly symptomatic present. So it's good to take away the people who are symptomatic, but it's not nearly enough. And most of the spread happens from people who don't know that they're sick.
Yeah, and I would add to that, pre-symptomatic spread is also a concern. So just because someone doesn't have symptoms, I mean, especially if you're talking about kids, especially young kids, who are more likely to be asymptomatic. I think basing all of your mitigation strategies on like symptomatic or symptom-based measures is dangerous. So it sounds like your district has, a testing plan in place that's quite comprehensive and seems good. But yeah, so asymptomatic spread is a big deal, and also pre-symptomatic spread. So you can be infectious for COVID even before you're showing symptoms, and symptom-based measures won't really help you in that case.
So my next one is about the new data coming out of the UK and the new mutation coming out of the UK that you guys talked about a little before. What do we know about the impact that has on kids? What do we know about the impact it has on schools? And some questions that I just got today from folks that I think are pretty straightforward, but I just want to make sure we touch on is, does the vaccine that they're rolling out work on this, mutation? And do the tests that we have still pick up that mutation as well?
So I can't answer all of that well, but I can answer some of it well. So there is a variant, it's being referred to, okay, back up a second. Viruses are mutating all the time. It's just how viruses work. And usually that doesn't mean anything. Sometimes a virus will mutate in a way where it can still be viable and it has an advantage over different ones. So there's this one, it's being called B117. It was first found in the UK. They found it in the UK first because they're testing the genetics of a big portion of their COVID cases there. We're not doing that in the US. It's already here. It's already in Massachusetts. It's not really being reported, but it's already here. And it's expected to probably become the dominant strain within the next couple of months. The virus, this strain doesn't specifically cause more severe illness, but it is about, they think, 50% more likely to be spread to another person. And that's very bad. And if you look at the line in the UK, it goes like, starts going straight up at some point. And I'm concerned, and also wouldn't be surprised if we see that in a lot of the US. I've heard, so I don't have specific information on whether it's specifically more transmissible in children. I don't know if if that's settled yet. It is more transmissible in children than the prior strain was. And I don't have a clear answer on vaccination. What I've heard is that the vaccine is likely to be pretty effective against B117. There aren't tests of that, so this is just inference based on the biology. But Abby might know more about that.
Yeah, so in terms of the vaccines, I was just reading a little bit about this like before I got on this call, and it seems like there's a lot of questions about this variant are unresolved at this point, but everything that I've read so far, researchers seem to be pretty optimistic that vaccines will still be effective against this against this variant. I think, yeah, I thought I had something more to say, but yeah, basically without getting like too technical and confusing, I think there's cautious optimism that the vaccines will still be effective. I think it's also true that testing is picking up this variant. It's just that in the UK, they're doing this, you know, like almost genetic testing. So they're able to distinguish this variant from others. But I think it's still kind of an open question. So I'm saying, I'm just relaying what I've read, and that information could change because I think this variant is still beginning to be understood.
Science takes time to get right. So, there are two pieces that I think are really like the heart of the mitigation strategies in Somerville, and you guys have talked about them already. One is, the HVAC updates, and the other one is the, mandatory surveillance testing. Can you just talk about like, A, how unusual that is, and B, why those things are so important and effective mitigation strategies?
Yeah, so most districts in the US that are doing in person are not doing any testing except if someone feels sick, which is bad for all the reasons we talked about. You might not feel sick ever, even if you're transmissible. You might not feel sick yet, even if you're still spreading it. New York City is doing a random sample of 20%. You can't, that's all that does is gauge the levels of infection, which then the politicians will spin however they want. It's not the same as protecting people. So what the universal testing that you're doing will be able to do is not just gauge how well the schools are keeping COVID at bay. It will also be an important tool to prevent spread by making sure people who are infected are not going around, making sure people who have been exposed are not going around and exposing others. Ventilation is like another key component. It's not perfect, but well-ventilated space can reduce the likelihood that someone will transmit to another person. This is usually measured with some metrics like air changes per hour. And you want like 4 to 6 or even more. There are classrooms in the US where there's very poor ventilation, and that's just going to facilitate spread. The issue is that there's the virus that causes COVID comes out in droplets of various sizes. Some are big and you can see them, and some are aerosols and microscopic and can stay suspended in the air for longer periods of time. So the more ventilation you have, the less you have to worry about the aerosols. And I think droplets are still an issue, but you have to be closer for droplets.
So like on that same page of the HVAC systems, right? A question that's come up a bunch is, Somerville is talking about updating their HVAC systems and getting at that ventilation issue that you're talking about. Other districts are talking about using, the portable like filters to try and clean the air. I don't, is there data on the, efficacy of those two things and like which is better? I don't know if there's an answer to that.
Yeah, I don't.
If there is data, I am not aware of it, and I truly don't know. It's beyond like the realm of my knowledge to be able to comment on whether HVAC upgrades or portable filters are better. I just don't know.
Yeah, same.
Cool. Easy one then. So the next one I had was about that testing requirement and the masking one. So Justin and I were talking about this a little bit earlier, but in Somerville, they're talking about having a medical exemption for students to wearing the mask, and then also potentially for the testing requirement, for sensory needs, particularly for special education students. The question I have, and this is one of the ones that I'm personally most concerned about is, there's probably going to be a lot of overlap between the students in that situation who would be exempted from one and the other one. So if that is such a huge piece of our mitigation strategy that people are wearing masks, and they're being tested, what impact does that have if you have individuals in the group who are not, doing those things?
Yeah, my assumption is that increases the level of risk that someone could introduce the introduce the virus. Someone who is carrying the virus and potentially doesn't even know it could come to school and potentially transmit it to somebody else. I had written down, I think exemptions from both of those things are potentially, the most risky. If one or the other are able to be met, that would be not ideal, but that would be less risky. But I definitely think, it's an increased risk to have students that are exempted from testing and exempted from wearing masks. And I'm not really sure, there might be other types of mitigation strategies or other testing strategies that might be possible for students who are not able to be tested, regularly, or who are going to be exempt from wearing masks, but I'm just not sure. But my common sense tells me that is, a riskier situation.
Yeah, it's concerning. It's also concerning because if they're not wearing masks and they have this exemption for masks in the building, they also aren't wearing masks outside the building, and then they're more likely to be infected in the first place. So it's just a bad situation.
So, the big question in Somerville right now is this idea of that there should be thresholds for levels of community transmission in order to determine when we're in person and when we are remote. So the question I have for you guys is, first, given the mitigation strategies we have in place, can someone make an argument that it doesn't matter what the level of transmission is in the community because we have all these mitigation strategies in the buildings and it will make it, safe. And if that is not the case, what are your thoughts on thresholds in order to make that determination?
I think that high levels of spread in the community makes every activity more risky and potentially more dangerous. So, I think if you open schools with very high levels of spread in the community, it's much more likely that someone, that the virus will be introduced into the school setting, right? That someone will pick it up somewhere in the community and then possibly bring it into school. I think that proper mitigation measures can make it less likely that such an introduction will result in further transmission. But as we've discussed, mitigation strategies are potentially more fallible if you're having lots and lots of introductions, right? If lots and lots of people are picking this up in school and bringing it, or picking it up in the community and bringing it into school, it's more likely that eventually, one of those introductions might result in a transmission. I think my opinion is that the optimal strategy is to achieve lower community spread by prioritizing closures of other things, and potentially implementing other restrictions plus mitigation measures. But I don't feel comfortable saying that, with good mitigation measures in place, it doesn't matter what the level of community spread is, because, mitigation measures aren't perfect, and you're likely to have a lot of people who are positive for COVID, entering school, potentially not even knowing it, if, spread in the community is as high as we're seeing. I don't know if Justin has anything to add.
Yeah, no, I think that's right. If you care about the number of transmissions that occur in the school, so there's a term called an attack rate. So what percent of people who are exposed to someone who's infectious get COVID? Let's say the measures work really well in Somerville and you get an attack rate down to 1%. So you need 100 infected people to result in one transmission. What if you have 1,000 infected people? Then you got 10. What if you have 5,000? Then you have 50. It's like, it just keeps going up from there. So there's no like clear guidance that's actually meaningful and based in strong science on like what is the correct level. And again, like I'll just reemphasize what Abby said, schools are not being prioritized, meaning the governor is refusing to close down other things that could lower the level of COVID in the community. In fact, Charlie Baker has specifically said, and I know because I'm writing an article about this, COVID doesn't spread at work. COVID doesn't spread in well-controlled environments. It spreads through social gatherings, through parties. This is bullshit. It spreads anywhere where people are near each other, especially when it's indoors. And he's using this, and he's not the only one. Just about every governor in the country is saying the same thing as an excuse to keep businesses open and just blame individual behavior.
Yeah, viruses have only one objective, and that's to make more copies of themselves. So, viruses don't draw distinctions between different types of gatherings, right? Like any type of gathering is potentially a place where transmission of a respiratory virus can occur.
Awesome. So I just have two more questions. I'm going to open it up to the group. So the first one I had just occurred to me right now is, as you guys are talking about things, I'm noticing that you're not saying this is safe or that this is unsafe, but instead you're talking about this is riskier, this is less risky. Can you just talk about like the distinction between those two ways of thinking about what we're doing and choices we're making? I think that'd be really helpful.
Justin, do you want to
Sure. So often in public health, this is how we talk in terms of risk rather than safety. Safety is like sort of this less clear. I think when you tell someone this is safe, they think I'm going to be protected. Everything's going to be fine. We can't guarantee anything. No one can guarantee anything. What we can say is that there is a continuum of risk where at one end, you're less likely to get COVID and less likely to transmit it to others. The other end, you're more likely to get it and you're more likely to transmit to others. And it's a continuum. If you have more testing, it'll be safer than if you have less testing. If you have more air changes per hour, it'll be safer than if you have fewer air changes per hour. The problem is we can't put precise numbers on any of this in any meaningful way because the research isn't there yet. Part of the reason the research isn't there yet is because the CDC's not been doing their job on this.
Yeah, that's essentially what I was going to say. It is not possible to say that there's, well, I'm sure that there is somewhere such thing as like a zero risk or a safe situation, right? Like I'm sure, if I barricaded myself in my room and didn't leave it for 10 months, like that would be probably 100% safety. Like I would be comfortable saying like there's zero risk that I'm going to catch COVID. But yeah, I think this thinking in terms of continuum, like a continuum of risk is smart. I had another thought, but I lost my train of thought, so I'm going to stop.
Then my last question is just, Justin, you hinted at this a little earlier that you were anticipating with the new variant that the numbers are going to be going up right now. I was just like wondering what your guts are right now. Do we think that the numbers are going to continue to rise? Do we think that they are going to dip now that we're out of the New Year's range? Like, what are you guys predicting, expecting? And if you're like, I don't know, that's a totally valid answer.
I tend to be, I've never been accused of optimism, or rarely, let's say. But if you just look at the direction Massachusetts and other states are going, it's a very bad direction. And that's before we have the new variant kicked in. I combine one, the direction that the state and other states are going, two, the lack of willingness on the part of governors and other leaders to close down the things that need to be closed to the extent that they need to be closed. 3, the new variant becoming more predominant. This combination of factors makes me think things are going to be very bad, and should also be thinking about, as is happening in parts of the country already, healthcare being rationed because the system's just overloaded. And that's, to me, a bad place to be doing in-person instruction when you can't be assured that there's enough oxygen supply or enough hospital beds, even if you don't even have COVID, even if it's something else.
Yeah, I will add, I'm kind of just thinking about this based on my knowledge of kind of molecular biology that's quite old at this point. So, take this with a grain of salt, but I agree with Justin. I think things are headed in a bad direction. I think things can be expected to get much worse before they get better. And I am also worried about rolling out the vaccine in this kind of like incomplete and quite slow way that we're doing it, in a setting where basically nothing is being done to lower the level of spread of this virus, because I believe, if I'm correct in thinking about this, and I might not be, such a strategy of introducing a vaccine, slowly in a situation of basically unmitigated spread can put selective pressure on the virus itself and might make it more likely that the virus can evolve to be, resistant to the vaccine or to overcome the vaccine. So I think it's not a pretty picture for the next couple of months, and I think a lot of caution is warranted wherever possible.
All right, those are all my questions. So thank you guys so much. If anybody else has a question, if you just write Zach in the chat, we can just go in order. I don't even need to call on you. You guys have done this enough times now that you can just do this. So go for it.
Good evening. I was wondering, when we were introduced to the SPS protocols, COVID protocols yesterday as staff, there was a slideshow, and it didn't include a questionnaire for staff and students about sick family members. There was no regard for household members who would be showing symptoms, and we were told that nope, you just wait until you have those symptoms. So basically going in, spreading, so I guess it's more of an awareness. I mean, I know the answer but would that be very useful information to help slow the spread of the disease? Is that something that should be included in a form?
Definitely. So we're talking about quarantine, which means someone who has COVID, their contacts are supposed to not leave the household. It's probably lower for the youngest children. If you have a household member who has COVID, there's on average, a 1 in 7 chance they're going to spread it to you. Higher than 1 in 7 if you live in crowded conditions where everyone's on top of each other. So yes, if someone lives with someone who's tested positive recently, definitely they should be quarantined. If someone lives with someone who's a likely case, it'd be a good idea to quarantine them too. So.
Thank you.
Am I next?
Yes, you're next, Ian.
So what, on your continuum scale of risk there, transmission via touch, via surfaces, if somebody's wearing a mask and they don't touch their face because they're wearing a mask, and they wash their hands before they take off their mask, where on if they're physical touch of the virus, as far as when I'm referring to, I'm a vocational teacher where the same student would have to touch the same item. Many students would touch the same item as opposed to wiping down the item each time. So the continuum of wiping it down each time as opposed to not wiping it down if you're wearing the mask.
That's hard for me to answer because I'm like a total hypochondriac. I'm like a little bit obsessive compulsive. So my my like risk tolerance is really low, even though I think it's I'm not totally clear on what the like body of evidence around you know, spread via surfaces or high touch surfaces is, but it's my understanding that spread via surfaces is a lot less of a concern than spread via respiratory droplets. I'm sure that it's possible, you know, like I'm sure it's possible if someone coughs, you know, directly on their hand and then opens a door and then, you know, I come along and open the same door and touch my eyes, like I'm sure it's possible that I could become ill that way. I think like the way you've described it, you know, if children are washing their hands and are fully masked, you know, the whole time, I would imagine that it might be, it wouldn't be, I don't think like the riskiest thing in the world, not to have to wipe down like a high touch item after, you know, every use. But I also think that it probably couldn't hurt to do that. But again, that's like my risk tolerance and like where I would fall based on my understanding of the science. So I don't feel comfortable telling you like one way or the other, like, yes, this is unsafe, or yes, this is, you know, much safer. But yeah, I would imagine that that's probably, if hand washing is really good and mask compliance is really good, then that's probably not going to be like a major risk. But I don't even know if I feel comfortable saying probably not. Sorry for that very like heavily qualified answer. That's like the most epidemiologist thing in the world.
Yeah, no, but I think that does reflect the research, which is pretty unclear. There is a consensus that touch transmission, surface transmission doesn't play a huge role. But beyond that, like how much risk is there? Hard to say.
Abby, I think you're muted.
Sorry, I was going to say relative to respiratory transmission, I think it's pretty clear that touch transmission is not that risky. But in absolute terms, how risky touch transmission is, I don't feel really qualified to say.
Julie Salas, I think you were next.
Great. Hi, my question's about close contacts. At that same meeting we had yesterday about protocols, they told us that like if a student or a staff member that's been in our classroom tests positive, then it's up to us to really figure out who the close contact is. And they said, you know, it could be 15 minutes within six feet. And I'm worried about really trying to keep track of that on a day-to-day basis. And also, because my son is in a hybrid model right now, and I've been notified several times that a person in his class has been testing positive. He's in high school. However, he's not a close contact, so I don't have to worry about it. So I'm just wondering, like, what are your thoughts on close contacts? And then really, how are we supposed to keep track of that? I don't know.
So Justin, Justin, can I jump in for just 1 second?
Yeah.
So yesterday's presentations across the district had, let's say, varying information that was not always consistent. I want to like be as clear as I can with everybody here that this is something that I have talked with the superintendent about, and your whole class is going to be a close contact. So if there is a positive infection in a class, that whole class is going to be quarantining. That is not going to be an issue. You know, I don't think that anyone's thought about what happens at middle school and high school because we're very far from there in terms of those students working in different groups. But in terms of, you know, your class as a classroom educator, right, that whole class is going to be a close contact. You know, with service providers, the people that are moving between classes, that's not as clear cut. We will need to figure out what that definition is. But in terms of like a class is all a close contact. No one is going to be asked to log how many minutes they were close to somebody.
Okay, good, because that's not the information I got yesterday.
I know.
I'll just add that I see a big shortcoming of what other schools are doing is gradually or quickly trying to dilute the concept of quarantine, because quarantine is very disruptive to in-person learning. Sometimes classes will find themselves very often going back to all virtual. And one of the points I raised at the meeting last night was, if community rates and therefore infections among students and staff are so high that you're going back to quarantine all the time, at what point do you decide it's no longer worth it?
Thank you.
I think I'm next. Sorry, I'm going to leave my camera off because my internet's been awful, but thank you both for coming. My question we kind of touched on about the data in schools, but I keep hearing that there isn't transmission happening in schools, but then I'm also hearing that like virtually no schools are doing the surveillance testing and a lot of kids are not showing symptoms. And so I was just curious what how trusting you are of this data that we keep hearing about, that it's not transmitted in schools.
I think that you're not going to find something that you're not looking for. And most schools and most municipalities, most states are not looking in schools and are not collecting the kind of data that they would need to collect to make a determination about whether transmission is happening in schools. But I think there is some data from other places that I'm going to maybe put Justin on the spot a little bit to talk about.
I think it's helpful to think, and maybe Rami can send out the Medium post Abby wrote about this. There was this sort of consensus in the media, let's say narrative in the media, that the consensus among health experts was that schools are safe and transmission is not really occurring in schools. And they made it seem as that was a uniform opinion out there. That's what all the experts and evidence said. It turned out that it was like the same two people being interviewed and writing these op-eds. And those same two people are like funded by organizations that have history of being opposed to teachers unions and being for the charterization of public school. So they have agendas and they're putting spin on the data. It's very clear that in places with without good mitigation, there have been bad outbreaks. In fact, sometimes they've been covered up. Even in Germany, which I would think of as more transparent than the US, there was a major outbreak and it only came out months later that it happened in school, not outside school as they had been claiming. So yeah, it's happening. It certainly happens less when there's really good mitigation in place, but again, we can't put a number on it.
So I just put a link to Abby's Medium post in the chat so folks can find it. It was already open on my computer in my list of things that I'm reading as I play the role of an amateur epidemiologist in the world today. A quick follow-up question, because you brought it up, Justin, is, some things that get quoted a lot at us is going to be the Path to Zero report, which maybe Abby can speak to a little bit. And then the other one is, the data coming out of Brown. And I was wondering if you could talk about random sampling representative of the population and why that's so important and why that's not happening there.
Are you asking me or are you asking Justin? I can start and then maybe Justin can fill in. So wait, I'm sorry. The first part of your question was regarding.
Well, the first one was the Path to Zero report.
Yeah. So I haven't looked at the Path to Zero report in a while. I think the last time I looked at it was before the break, or in December. But the thing that really struck me about the Path to Zero report is that it was kind of using data from this dashboard from Brown University to argue that, teachers aren't at excess risk of contracting COVID relative to other what the report calls low risk workers, like grocery workers, which I don't agree with that characterization. The Path to Zero report claims that, yeah, staff and students are not at increased risk relative to other, members of the community as a result of in-person instruction. And also argues that the level of community spread doesn't matter in determining what the safety of schools is. And I disagree with that claim. I think there was actually another Medium post that I just read before I got on this call by someone named Joshua Jacobs, who is a neuroscientist, I believe, at Columbia, who reanalyzed some of the dashboard data, the Brown University dashboard data, and showed pretty strikingly increased rates of infection among school staff as rates of community spread increased. And I can, I'll link to that. I can put it in the chat. The major issue with the Brown University dashboard is, like you said, reporting of case information to the dashboard is voluntary at the discretion of, districts or individual schools. And that is kind of a problem because, you can imagine just from kind of a purely like political standpoint, you can imagine that, schools that are participating in the dashboard might be incentivized, to underreport or to not report certain, to not report cases. Justin and I had talked to some teachers in the state of West Virginia, and I was looking around on the dashboard, for data that was specific to West Virginia, and there basically is none since August. Like none of the participating schools or districts have submitted any of this data that's voluntarily submitted to the dashboard since August. So the data is really incomplete. And I think, in West Virginia's case, there's not much data. I think also in terms, the question of, I'm sorry, my cat is like being super distracting. In terms of why like random sampling is important, in most places, people are seeking COVID tests only when they're showing symptoms or when they've, been notified or, have found out in some way that they've had an exposure and need to get a test, which is a problem because we know that some COVID infections are asymptomatic, and it's especially a problem for children because we know that like a larger proportion of infections are asymptomatic among children. So testing that is only done kind of on a symptomatic basis is likely to underestimate the level of infection that there is in a given setting, but that is the kind of data that is being reported to the Brown University dashboard. And even, even of the case, there's this let's say this like population of cases, like people that are positive for COVID-19. And then there's maybe like a smaller subset of that population that's showing symptoms. And then there's maybe an even smaller subset that is seeking a test based on their symptoms. And then of those tests that come back positive, it's not clear what the procedures are for each of these individual schools, and districts that are going into the dashboard, what their procedures are for getting information about positive tests and, reporting positive tests to the dashboard. There's, as far as I know, like there's no requirement. I know, it's so variable how schools are approaching testing, but I know in a lot of places, testing is just symptomatic and like parents and students are basically under no obligation to report a positive test to the school. So I feel like the dashboard is, the Brown University dashboard, it's like an interesting tool and it's potentially useful data, but there are definitely problems with the data, and there's reason to suspect that the data on the dashboard are not an accurate picture of what the state of infections are like. Does that answer your questions? I feel like I just talked for a long time and like maybe was not totally coherent. So let me know if I can be clearer.
I thought that was great. Justin, do you have something you wanted to add?
Just to connect the dots from earlier, these are the groups that are funded by the anti-union foundations, and that are putting spin and are not just doing technical assistance, but talking to the media in a particular way and shaping the narrative. they're just making things up. When Joseph Allen at Harvard says, actually, it's fine to be just 3 feet apart when the case rate is under 100 cases per 100,000 population. He's literally making that up. There's no basis for it.
Awesome. I would just add then, I think this is also underscoring why the asymptomatic testing we're having in Somerville is so valuable and going to be a really effective mitigation tool. I think next up was Clayton. Or Abby, did you have anything you wanted to add?
No, I was just nodding emphatically and was going to say yes.
Awesome. Clayton.
Okay, cool. Thank you. I have a little bit of a vague / open-ended question, and so maybe it'll end up being inconsequential. But we've talked about various ways that sort of risk margins expand and contract, right? We talked about the ways that exemptions to various policies might increase risk, right? We talked about the ways that ventilation strategies might increase risk. We talked about, Justin mentioned in a sort of qualitative way, this idea of quarantine dilution and policies being weakened over time. So my question is, and it's broad because there's a lot of these different things, but do any of these various curves have strong inflection points where we do, we increase exemptions and we degrade the risk until it hits 80% and then the whole thing falls apart? Or are they all smooth, or do we just don't know because there's 8 million different curves and too many different variables? And and the motivation for my question is, if there are those points, that creates strong policy points of we have to keep this number above this, or else we get some cascading failure. Do any of those exist for any of the things we've talked about?
I think that's the $1 million question. I am not aware of anything that dispositively, wait, I don't know if I used the word dispositively right. I don't know of anything that definitively indicates, what mitigation strategies work best, at what level of community spread, mitigation strategies become effective or ineffective. There were, I feel like I wrote this down somewhere, but maybe I didn't, and I'll just have to wing it. But there were 2 kind of econometric studies that came out kind of recently that sort of attempted to get to what your question is, to ask at what level of spread do these measures work and not work? And there were, I think it was 2 studies, but it involved 3 data sets, and they all had wildly different answers for the level at which, the level of community spread under which, it's basically safe per the way that the researchers operationalized, everything that they were looking at to do in-person instruction. So yeah, I think that's a major open question, and it's really hard to get data that are adequate to answer that question. But I feel like the person who can answer it will be very famous indeed. But I don't know if Justin's more keyed into the literature, so I don't know if you...
That's true. So the research on this, there isn't much. It's not even peer reviewed yet. It's based on simulation, so strong assumptions. We can't answer it well. I would just reiterate what I said before, is masking and then the test and quarantine regimen. Those are going to be the 2 most important things. You're going to want to have those both functioning nearly perfectly. That's all I can say.
Can I ask one briefer follow-up question, which is, I think, a slightly different version of this, which is, we've talked about the B117 spread, and we've talked about the fact that right now we don't know what that's going to look like, right? Can you gut check, will it be 2 weeks before we know more about what that looks like? Will it be a month before we know what that looks like? Do you have some sense of when that knowledge, the existence of its spread or the effects of its spread will sort of start to kind of coalesce in the data?
So we know pretty strongly that it's 50% more infectious. So if someone was going to pass the virus on to, say, 4 other people, maybe they'll pass it on to 6 other people instead. But there'll be cases when they would have passed it on to 0 people, they'll end up passing it on to 1 or 2 people. It'll be all over the place, but on average, 50% more. and it's just going, it's gonna be bad. That's all I can say, unless miraculously it doesn't become the predominant strain here.
Yeah, I don't know that I know what the timeline might be to learn more about this variant. My sense is that it's already in the United, I mean, well, we know now that it's in the United States. My sense is that it has probably been, in the United States for longer than we've known to look for it. And I think that I don't know anything about timeline, but I feel like watching data from, for example, the UK is going to be more informative because, I mean, our testing infrastructure in the US is kind of a nightmare. And to my knowledge, like we're not doing extensive surveillance to determine, which variants of COVID are dominant. Maybe we are, and I just don't know what I'm talking about, but it's really hard to put a timeline. I don't feel able to put a timeline on it.
Yeah, I mean, Fauci kind of speculated that it would become the dominant form in the US in March. I don't know if that's been updated. And there was a study that uses not a random sample, so we don't know how good it is, but they found B117 as early as October in the US. And the Massachusetts sample had the highest amount of B117 in it than any other state. Not random sample, so maybe it's not, it's not actually the most here, but it's possible. There's something like 3% of COVID was B117 in Massachusetts.
Thank you.
Awesome. Amelia.
Yes. So earlier you mentioned that there's a higher risk of transmission among people living in crowded households. I'm wondering about other factors that might similarly be affecting some portions of our community more than others, particularly along socioeconomic lines, and if there are any specific countermeasures that we could or should pursue.
Yeah, I mean, the big factors that are driving inequality and infection rate are two things. One is housing conditions, and the other is work conditions. And often those go together. So someone who's being exposed more in the workplace also lives in more crowded conditions in the home, and that just amplifies infection. I mean, I think the countermeasures are one that our society has failed to take for the course of this pandemic and much longer, which is like pay more people to stay home, close non-essential businesses, protect essential workers better, there have been places, and even in the US earlier in the pandemic, where if someone was sick, they would remove them from the home and give them a safe place to stay for the course of their illness. We're not really doing any of that. We could do some of it.
Rob.
Hi, I'm not 100% sure if you're going to be able to answer this one. It's one that's related to the HVAC system and their plans that are relating to that. So one of their big claims is that the ventilation system is going to play a significant role in the risk reduction. And they're talking about using MERV 13 filters. And basically my question has to do with like the size of the particulates in the air as far as the virus goes, because those filters are only 80 to 85% effective for 1 to 3 micron. And they're only 35 to 50% effective when you go down to 0.3 to 1 micron. So do you feel that those are really a significant factor in reducing the risk?
I think you probably know more about this than we do.
Well, I just wasn't sure with I don't know what the sizes of like the virus are.
Yeah, so there's a spectrum of particle sizes that COVID exists in, and filtering some of those out is good, and there will be some remaining. Like all of the mitigation measures, they're partially effective, and the idea is that if you pile on multiple partially effective measures, they will together prevent most of the spread in ways that we can't put precise numbers on.
Thank you.
I am not seeing any more questions in the chat. Any last questions?
I always take that as a personal challenge. I do have another question.
Go for it, Clayton.
So we've talked about a lot of mitigation strategies, and I have this idea that I don't know where I've gotten it, and might be nonsense, which is that there's sort of two things that we could be doing, right? We could be saying, we'll make it so that if I walk into the school with COVID, nobody else gets it, right? Thing A. And thing B is we'll make it that I will only spread it within my classroom, but then we'll wall off the classrooms from each other. So folks in my classroom, they're kind of screwed, but nobody else's classroom gets it. Is that a distinction? Are those just on a spectrum, and have some of the measures that we've talked about been focused? Would they be more effective in one of those modes than in the other, if there are in fact different modes?
Justin, you want to go ahead? No.
Go for it.
Okay, I'm sorry. Can you repeat the first thing you said? So the second thing you said was like classrooms. Like,
yeah. Are we talking mitigation like it'll spread, but we will contain the spread? Or are we talking mitigation like it won't spread in the school? I walk in having it, I walk home having it, nobody else has it. Maybe this relates to the attack rate thing you were talking about before.
Yeah, I think that those things are sort of, maybe not on a spectrum, but potentially complementary. So, the idea is that you have, like Justin was just saying, like these multiple, all of these, I've been seeing these like infographics of like, the Swiss cheese model, right? Like all of these strategies have holes in them, but the idea is that it's like safest to layer multiple of these strategies, right? Like to reduce the potential for any one of those holes or weaknesses in an individual strategy to, result in an outbreak or result in transmission. So I think the idea is to try to do both, right? Like, and to try to minimize the likelihood that, that someone is going to, ideally, the idea is to minimize the likelihood that someone is going to come into school, being positive for COVID, then to minimize the likelihood that if someone comes into school who's positive for COVID, to minimize the likelihood that they're going to spread it. And then if, spread and transmission do occur, then the idea is to minimize the likelihood or to contain, that transmission as much as possible or to as few people as possible. So I think they're, just kind of like complementary strategies because none of them is perfect.
Yeah, and if you think about someone testing positive in a classroom on Monday, and then on Tuesday, nobody comes into school from that classroom, not only are you protecting others who are not in the classroom, you're giving the classroom one fewer day for that infectious person to spread. So it's aligned. I think they're complementary.
Thanks.
Kinga.
So I wanted to change things around a little bit. So there's been a lot of contradictory information about the effect on children. The Guardian recently in England put out a report that there were wards in hospitals full of children with COVID. And we've heard about children who have suffered from Kawasaki syndrome after being infected with COVID. The school district is talking about sending our most vulnerable populations in first. Our English language learners, our recent arrivals, our Black and Brown people. How deadly or how severe is COVID on people who, on children who may have other issues, malnutrition, obesity, other factors? What are we risking our most vulnerable children when we're sending them into the schools, regardless of transmission rates and mitigation factors?
I mean, yes, to some degree. Like there's there's debates on both sides of this, and like, would those same students not be getting the resources they need if they stay home versus if they come in? And I think you're probably all more qualified to weigh in on the benefits before you consider COVID risks, benefits of being in person or not. I won't weigh on that. As a rate, the likelihood that any one child has severe disease or dies from COVID is very low. There are inequalities. If you're Black or Indigenous or Latino and a child, you're more likely to have complications or to die than a white child, but the rates are still very low. For school-age children, it's been less than 300 have died from COVID in the US, compared to something like 350,000 older people. However, as you get, even if the rates are low, as you get more exposure, as the community rates go up, the numbers will go up too. So it's just like, it's not the number one thing I think about, but it definitely is a concern.
Adrian.
Yeah, this might be a crazy question, but I've heard a lot about transmission of COVID through the sewer system. And I was wondering, or not a lot, but I've heard some about it. And I was wondering, I haven't heard a lot of policies from the district around how we're gonna do bathroom procedures or anything like that. And I'm wondering also if you guys can speak to anything about what you know about the transmission of COVID through the sewer system, and is that something we should be talking about less or more, or is it relevant or not?
That's a really good question. I actually don't know anything. I don't know anything about this, and I haven't read anything about this. I don't know, Justin, if you have, but yeah, I'm gonna have to look that up, because I don't feel qualified to comment on that, because I really don't know.
There may be more since I last looked into this, which was maybe 2 months ago. There are some kinds of older plumbing, like U-shaped pipes or something, I can't remember exactly what it's called, where the whatever it is, poop, I guess, can hang out and causes issues around perhaps particles aerosolizing or something. There wasn't strong evidence of that. There's like a case study from not COVID-19, but SARS.
Yeah, that's what I thought of too.
Spreading in a building somewhere, likely through the plumbing, but it's just like not good data on it as far as I know.
All right, last call for any burning questions. All right, well, on that note then, I can't think of a better way to end than with poop. Justin and Abby, thank you guys so much for coming out tonight. I know that I've learned a lot. I'm sure other people have as well. This has been really, really helpful as people are trying to figure out how to evaluate risks and make choices.
Thank you guys so much for having us.
Good to meet you all.
Really nice to talk to you.
Thank you.
Thank you very much.